A very good morning to all. I am Dr. Nishitha Divakar, working as Assistant Professor at Sri Lakshmi Narayana Institute of Medical Sciences. Today's topic on lecture is liver physiology. The gross anatomy. Liver is the largest internal organ. It is the largest gland. The weight is a median weight of 1.8 kg in men and 1.4 kg in women. It accounts for about 2% of the total mass of healthy adults and 5% of neonates. Location is in the right hypochondrium. In the right mid-axillary line, the liver spans from the 7th to the 11th ribs. It is covered by peritoneum, which is the Glissen's capsule, except for the gallbladder bed, the inferior vena cava, the bare area, and the porta hepatis. The vascular supply of liver, 25% of the cardiac output is supplied to the liver. The average blood flow between 100 and 130 ml per minute per 100 gram. It has a dual supply. One is by the portal vein, which is formed by the confluence of the splenic and the superior mesenteric vein. It is 75% nutrient rich and contains about 50 to 55% oxygen. The second source is the hepatic artery, which is 25% oxygen rich and has about 45 to 50% of oxygen. The mean pressure in the portal vein is about 5 to 10 mmHg, whereas the mean pressure in the hepatic artery is about 40 to 90 mmHg. The venous drainage of liver, hepatic sinusoids drain into the central veins. The central veins drain into the interlobular and sublobular veins. The interlobular and sublobular veins drain into the hepatic veins, which eventually drain into the IVC. If thrombosis of the major hepatic veins occurs, that is the Budd-Chiari syndrome, the caudate veins become the key to the drainage of hepatic blood into the IVC. The caudate lobe is usually drained by its own set of veins. The lymphatic drainage, superficial lymph nodes are caval, hepatic, celiac, and paracardial, whereas the deep ones are the nodes around the IVC and hepatic nodes. Increase in sinusoidal pressure, that is, as in portal hypertension, leads to increased lymph production and hence ascites. The normal hepatic blood flow. Total hepatic blood flow is about 1200 to 1700 ml per minute, which is 57.7 ml per 100 gram per minute. That is about 25% of the cardiac output. The time it takes for the red blood cells to traverse from the portal vein to the central vein is approximately 8 to 9 seconds, allowing sufficient time for contact with hepatocytes and Kupffer cells. The hepatic blood flow regulation. Intrinsic factors and extrinsic factors are there. The intrinsic factors are regional microvascular ones, whereas the extrinsic factors are neural and hormonal. The intrinsic factors are responsible for the hepatic arterial buffer response, which is a vascular autoregulation. The extrinsic factors, that is, the factors that increase the hepatic blood flow are feeding, glucagon, beta 2 agonists, recumbent position, hepatocellular enzyme induction, acute hepatitis. Whereas factors that decrease the hepatic blood flow are anesthetic agents, surgical trauma, alpha agonists or beta blockers, IPPV, vasopressin, hepatic cirrhosis, and hypoxia. So, talking about inhalation agents and the hepatic blood flow, halothane causes maximum vasoconstriction in hepatic arteriolar vascular bed, reduces the hepatic O2 delivery and hepatic venous O2 saturation. It disrupts the hepatic arterial buffer response. Enflurane has the same effect as halothane but with lesser intensity. Isoflurane or sevoflurane maintains hepatic arterial buffer response. Sevoflurane is also consistently equivalent or superior to isoflurane in maintaining hepatic arterial buffer response, hepatic O2 delivery, and O2 delivery to consumption ratios. So, in a case of a liver disease, Sevo is better than iso, better than desflurane, better than enflurane, better than halothane. Xenon, it does not alter the hepatic arterial buffer response. It also does not alter the results of the liver function tests. Now, effects of anesthesia on the hepatic blood flow. IV anesthetic agents, they decrease the portal vein blood flow. Total hepatic blood flow is unchanged. Propofol is the best IV induction agent as it does not disrupt the hepatic arterial buffer response. Thiopentone or etomidate, it decreases the total hepatic blood flow. whereas propofol increases the total hepatic blood flow by causing splanchnic vasodilation. Ketamine has no effects. Ventilation, spontaneous, there is no change. IPPV, there is decreased hepatic blood flow. It reduces the venous return and decreases the cardiac output. Positive end expiratory pressure further accentuates these effects. Central neuraxial blockade, the decrease in NAP causes a decrease in the hepatic blood flow. The spinal block to T5 level, it causes a decrease on the hepatic blood flow up to 23%. Hypoxia, vasoconstriction in the splanchnic and hepatic vasculature decreases the hepatic blood flow. Hypoxemia decreases hepatic blood flow via sympathetic activation. And effect of hypoxia depends on the duration, degree, and anesthetic used. PaCO2, hypocapnia causes vasoconstriction, so this will decrease the hepatic blood flow. Whereas hypercapnia causes vasodilation, and this will increase the hepatic blood flow. Sympathetic stimulation decreases the hepatic blood flow. Effect of surgery. Surgical procedures near the liver can reduce hepatic blood flow up to 60%. Probable mechanisms. Sympathetic activation, local reflexes, and direct compression of vessels in the portal and hepatic circulations. Hepatic functions. So one of the hepatic function is carbohydrate metabolism. Liver is an important homeostatic regulator of blood glucose. It can either produce glucose or store glucose. In fed state, the liver polymerizes glucose to glycogen by glycogen synthase. This process is called glycogenesis. In unfed state, depolymerize the glycogen to glucose by glycogen phosphorylase, and this process is called glycogenolysis. When liver glycogen stores are depleted, the hepatic gluconeogenesis occurs to replenish blood glucose. Gluconeogenesis is the formation of glucose from non-carbohydrate sources. So substrates for gluconeogenesis would be lactate, glycerol, which is obtained from the hydrolysis of triglycerides, gluconeogenic amino acid, alanine, and glutamine. Another function is lipid metabolism, that is beta oxidation of fatty acids. It produces acetyl-CoA. The beta oxidation of fatty acid produces acetyl-CoA, which enters the citric acid cycle or ketone body synthesis. Synthesis of lipoproteins. One of the major functions of the liver is synthesis of lipoproteins. Major classes are VLDL, LDL, and HDL. VLDL, acute or chronic liver disease, the ability to produce VLDL is markedly compromised. LDLs and HDLs, liver produces them in very small amounts. Production of ketone bodies. Most organs, except the liver, use ketone bodies as fuel. Ketone bodies are acetoacetic acid, acetone, beta hydroxybutyrate. Their formation by the liver is normal and physiologically important. Example, in a state of fasting, rapid depletion of glycogen stores in the livers occur. Shortage of substrates for the citric acid cycle causes the acetyl-CoA from the beta oxidation cycle forming ketone bodies. Whereas ketosis, there is increased concentration of ketone bodies in blood. Starvation, diabetes mellitus, and after high fat diet, in these scenarios, ketosis can be seen. Synthesis of cholesterol. Important role in cholesterol homeostasis. Liver cholesterol has both exogenous and endogenous source. Uses of hepatic cholesterol. Formation of bile acids conjugated with other substances to form folic acid. And also synthesis of VLDLs. Bile metabolism and enterohepatic circulation. Bile salts are end products of cholesterol synthesis. The daily production ranges of about 600 to 800 ml per day. Functions: activate lipase, promote micelle formation, intestinal uptake of fat-soluble vitamins, cholesterol, and lipids, facilitate excretion of xenobiotics, lipophilic substances, bilirubin, amphipathic steroid hormone derivative. Bile salts undergo enterohepatic circulation that is about 20 to 30 times per day. So the clinical implication of this is opioids can induce a spasm of the bile duct and sphincter of Oddi, which is maximum seen in administration of fentanyl. This can be reversed by glucagon, opioid antagonists like naloxone, smooth muscle relaxants like NTG, anti-muscarinic drugs that is atropine, and volatile anesthetics. Protein and amino acid metabolism. Deamination of amino acid and formation of ammonia is also done in the liver. Formation of urea from removal of ammonia from the body fluids by the Krebs translate cycle or the urea cycle. If this cycle is failed, what happens is the ammonia accumulates in the blood and this can cause hepatic encephalopathy. Production of proteins and peptides. First is albumin, most abundant protein. Its normal plasma concentration is about 3 to 5 gram percentage. And the daily production, if you see, is about 12 to 15 gram per day. The plasma half-life is about 15 to 20 days. So this is not an indicator of acute disease. The functions of albumin are maintains plasma oncotic pressure, which is 80% is maintained by albumin only. It binds to ions, bilirubin, hormones, and drugs. Now, in case of hypoalbuminemia, there will be decreased colloid oncotic pressure, which can lead to edema. Hypoalbuminemia is more common in chronic liver disorders such as cirrhosis and usually reflects severe liver damage. Another protein produced by the liver is globulins, all globulins except Ig. Coagulation. The liver synthesizes most of the procoagulants except factor 3, factor 4, and factor 8. Factor 3 is tissue thromboplastin. Factor 4 is calcium. Factor 8 is von Willebrand factor. So the liver also produces protein regulators of coagulation and fibrinolytic pathways, which are protein C, protein S. Protein C, it inactivates the factor 8A, the complex that is formed between factor 8A and fibril. Whereas protein Z, it causes the degradation of factor 10A. Plasminogen activator inhibitor, that's PAI, inhibits tissue plasminogen activators to convert plasminogen to plasmin. And another protein regulator is antithrombin 3. Fibrinogen, synthesized exclusively by hepatocytes. Plasma fibrinogen levels are about 100 to 700 milligram per deciliter. The functions of fibrinogen are it polymerizes into long fibrin threads by the action of thrombin, and this results in the formation of clot. Clotting factors, rapid turnover, that is, factor 7 has the shortest half-life, 2 to 6 hours, hence, best measure of acute hepatic dysfunction. Prothrombin time is the best test. The prothrombin time, which is normally 11 to 14 seconds, measures the activity of fibrinogen, prothrombin, and factors 5, 7, and 10. Bilirubin metabolism. So the main source of bilirubin is heme metabolism, that is from the porphyrin ring. Daily production is about 300 milligrams. 80% of the derived from the senescent erythrocytes by macrophages in reticuloendothelial system. So the heme in the hemoglobin is broken down by heme oxygenase and oxygen to give biliverdin and carbon monoxide and a free divalent ion. From biliverdin, the biliverdin reductase brings about its action, converting the biliverdin into bilirubin. Carbon monoxide produced has many physiological roles. It causes vasodilation, platelet aggregation, vascular myocyte proliferation, neurotransmitter release, cytoprotective, anti-apoptotic, and antioxidant effects. Biliverdin confers protection from oxidative effects, rapidly converts to bilirubin. Blood reservoir. Liver is an expandable organ. 10 to 15% of the total blood volume can be sequestered and quickly released after sympathetic stimulation. Immune and inflammatory responses. Kupffer cells protect against foreign intrusions, degrade toxins, process antigens, and phagocytose bacteria. They also induce and intensify inflammation by recruiting neutrophils, release pro-inflammatory mediators. Hematological function is hematopoiesis, 9th to 24th week gestation, clears fibrin degradation products and lactate, important in shock and massive blood loss and transfusion. Endocrine functions. Liver can modify or amplify hormone action, that is metabolic conversion of vitamin D to form 25 hydroxy D. 25 hydroxy D is converted to 1, 25 dihydroxy D in kidney. Peripheral conversion of T4 to T3. All these are the hormonal actions that occur in the liver. Pseudocholinesterase, hydrolysis of succinylcholine, that is the plasma T half is about 14 days. And in severe liver disease, the increased duration of action of succinylcholine. So it also removes the circulating hormones like insulin, glucagon, growth hormone, gastrointestinal hormones like gastrin. Metabolism of drugs, that is xenobiotics. Phase 1 reaction. It converts drugs to more polar compounds. The reactions that occur in the liver are oxidation, reduction, hydrolysis, and N-acetylation. The main enzyme is cytochrome P450, which is the substrate binding site and is located in the endoplasmic reticulum. The drugs that are metabolized by phase 1 reactions are barbiturates, benzodiazepines, halogenated volatile anesthetics, pethidine. Whereas phase 1 reaction enzymes are more susceptible to destruction in cirrhosis. Phase 2 reactions, it creates conjugates of parent compound or its metabolite with endogenous hydrophilic substrate. The reactions that are included in phase 2 are glucuronidation, sulfation, methylation, and acetylation. In this, the major one is glucuronidation, which is the most common type. Hepatic microsomal enzyme, UDP glucuronyl transferase, this mediates the transfer of glucuronic acid from UDP glucuronic acid, the functional group on the xenobiotics. Drugs that undergo glucuronidation are morphine, propofol, and haloperidol. The phase 2 reaction enzymes, they are more resistant, function even in the advanced liver disease. So talking about the hepatic drug clearance, this is governed by three factors. The rate of hepatic blood flow, plasma protein binding of the drug, and hepatic intrinsic clearance. The clearance is, what do you mean by clearance? It is the volume of blood from which the drug is completely removed per unit time. So the extraction ratio provides a measure of the relatively efficiency with which the liver extracts or eliminates a given drug. The formula for clearance is hepatic blood flow into extraction ratio. Liver function tests. The uses of liver function tests are to detect the presence of liver disease, to distinguish among different types of liver disorders, to know the extent of known liver damage, to follow the response of the treatment. Whereas the disadvantages are it rarely suggests any specific diagnosis. Now, the enzymes that reflect damage to hepatocytes. So, if these levels are increased, it means that some hepatocellular damage has occurred. Aminotransferases. Aspartate aminotransferase, that is AST or SGOT, it increases in liver, cardiac muscle, skeletal muscle, kidneys, brain, pancreas, etc. Alanine aminotransferase, that is ALT or SGPT, which is primarily produced in the liver. Sensitive indicators of liver cell injury. The normal levels should be less than 35 to 45 international units per liter. So they are graded into mild, moderate, and large. That is, mild elevation less than 250 can occur in any pathological process that causes hepatocellular injury. Example, hepatic steatosis, alcohol, or drug-induced liver disease, chronic viral hepatitis, cirrhosis, hemochromatosis. Moderate 250 to 1000 international units per liter. Disorders that produce hepatocellular necrosis, like acute viral hepatitis, drug-induced hepatitis, exacerbation of chronic hepatitis due to alcoholism. Large is more than 1000 international units per liter. Viral or drug-induced liver damage, so superimposed on acute liver disease, autoimmune hepatitis. So there is something called the AST to ALT ratio, which is called the Deritis quotient. Normally, it is 1 or just slightly more than 1. If it is less than 1, non-alcoholic steatosis or hepatitis without cirrhosis. If it is 2 to 4, it is alcoholic liver disease, whereas if it is more than 4, it is Wilsonian hepatitis. Now, the ratio AST to ALT not only increases in purely obstructive disorder, but uh, that is except in acute biliary obstruction caused by passage of gallstones to common bile duct. LDH normal level is 25 to 100 international units per liter, massive but transient, seen in ischemic hepatitis. Massive sustained is seen in malignant infiltration of liver. Other causes of increased LDH: hemolysis, renal infarction, acute stroke, myocardial damage, skeletal muscle injury. Enzymes reflecting cholestasis. So, alkaline phosphatase, which is present in the cells of the bile duct, they increase in ALP will reflect cholestasis. Isoenzymes, they are present in the bone, liver, intestine, placenta, kidney, leukocytes. The normal levels are 42 to 122 international units per liter. Non-pathological increase is seen in age more than 60 years, blood group O and B, growing children, and adolescents, late in normal pregnancy. Whereas pathological increase is seen in primary biliary cirrhosis, choledocholithiasis, hepatic malignancy, and Paget's disease. Alkaline phosphatase is an enzyme localized near the bile canaliculi and is elevated in biliary obstruction, non-specific to hepatobiliary disease. That is, it is raised in malignant bone disease. 5' nucleotidase, sensitive and specific for hepatobiliary disorders. Normal pregnancy, bone growth, and bone diseases do not affect 5' nucleotidase. In patients with hepatobiliary disorder, changes in ALP are usually followed by similar changes in 5' nucleotidase. Gamma glutamyl transferase, that is GGT. Inducible microsomal enzyme is GGT, whereas the normal levels are 5 to 40 international units per liter, less specific than 5' nucleotidase as a marker of hepatobiliary disorder. Unlike 5' nucleotidase, GGT may be released from many sites beside the hepatobiliary tree. Bone is an important source of ALP and it has little GGT. Thus, an accompanying rise in GGT suggests that the ALP is from the liver. Serum bilirubin. It is found in blood in two fractions, that is conjugated and unconjugated. Conjugated, water soluble, so it is excreted by kidneys. Unconjugated bilirubin is insoluble in water, so this is bound to albumin in blood. Normal total serum bilirubin is about 0.3 to 1.3 milligram per deciliter. Direct to or the unconjugated bilirubin, direct or the conjugated bilirubin is about 0.1 to 0.4 milligram per deciliter, whereas indirect or unconjugated bilirubin is about 0.2 to 0.9 milligram per deciliter. It is measured by the Van den Berg method. Bilirubin reacts with diazo reagent to produce colored azo pigment. At pH 5, the pigment is purple in color. So plasma bilirubin exceeds 1 milligram per deciliter. It is termed as hyperbilirubinemia. Between 1 and 2 milligram per deciliter, it is latent jaundice. More than 2 milligram per deciliter, the yellowish discoloration of sclera, conjunctiva, skin, mucous membrane is seen, which results in jaundice. Serum albumin is less than 3 gram per deciliter, where you can suspect chronic liver disease. Hypoalbuminemia is not specific for liver disease. It is also seen in protein malnutrition of any case, protein losing enteropathies, and nephrotic syndrome. Serum globulin. Increase in gamma globulin is seen in chronic liver disease. IgM, there is an increase in primary biliary cirrhosis. IgA is seen in alcoholic liver disease. IgG is seen in autoimmune hepatitis. The reversal of A albumin to globulin ratio is seen in chronic liver dysfunction. Coagulation factors. Short T half of factor 7 is causes this prothrombin time and the INR to be a sensitive best measure of acute hepatic synthetic function. So the prothrombin time, the normal time is about 11 to 16 seconds, whereas the APTT is 30 to 40 seconds. Prognostic value, if the prothrombin time is more than 5 seconds above the control, it indicates a poor prognostic sign in acute viral hepatitis. Whereas if the prothrombin time is very high, it is seen in hepatitis, cirrhosis, disorders leading to the vitamin K deficiency, such as obstructive jaundice or fat malabsorption. So, talking about jaundice, the differential diagnosis of jaundice, it can either be prehepatic, or it can be hepatic, or it can be obstructive. So, the basic metabolism or mechanism of raised bilirubin in prehepatic is because of hemolysis. In hepatocellular is because of deficient uptake and conjugation or excretion by the hepatocytes. Whereas in obstruction, it is due to the deficient excretion due to obstruction of the biliary tract. The type of serum bilirubin, mainly unconjugated in prehepatic and conjugated in obstructive, whereas both are seen in hepatocellular. Urine bilirubin is absent in prehepatic, whereas it is present in both hepatocellular and obstructive. Urine neurobilinogen is increased in prehepatic and decreased in obstructive, whereas it can be variable in hepatocellular. Prototype, if you see, main cause would be hemolytic anemia in prehepatic, viral hepatitis in hepatic, and common duct stone in obstructive. Prothrombin time is normal in prehepatic. It is abnormal in both hepatocellular and obstructive. Additional features of hemolysis is seen on blood smear, that is reticulocytosis, low haptoglobulin, low hemoglobin. Marked rise of serum ALT and AST seen in hepatic jaundice, whereas marked rise of serum ALP more than 3 times of normal is seen in obstructive jaundice. Cirrhosis. Chronic generalized liver disease is called cirrhosis. The pathological features are development of fibrosis to the point that there is architectural distortion with formation of regenerative nodules, which can either be micronodular or macronodular. This results in decrease in hepatocellular mass, and therefore the hepatic function is also decreased. Pathogenesis, hepatocellular death, regeneration, and then causing progressive fibrosis. The induction of fibrosis occurs with activation of hepatic stellate cells, resulting in formation of increased amounts of collagen and other components of extracellular matrix. Stimulus. So the first chronic inflammation occurs due to cytokines like TNF, lymphotoxin, and interleukin 1. The cytokine production by injured Kupffer cells, endothelial cells, hepatocytes, bile duct, epithelial cells. Then there is disruption of the endocapillary membrane. Then there is direct stimulation of the stellate cells by toxins. So etiology. What are the causes for chronic, that is cirrhosis? Alcoholism, chronic viral hepatitis, which can either be hepatitis B or C, autoimmune hepatitis, non-alcoholic steatohepatitis, biliary cirrhosis, primary biliary cirrhosis, primary sclerosing cholangitis or autoimmune cholangiopathy, cardiac cirrhosis, Budd-Chiari syndrome, inherited metabolic liver diseases like hemochromatosis, Wilson's disease, alpha 1 antitrypsin deficiency, or cystic fibrosis. Now, impaired liver function, direct effects. Impaired liver functions will lead to hypoglycemia, lactic acidosis, hypermetabolism, azotemia, and impaired urea synthesis. Jaundice appears when bilirubin exceeds 35 micromoles per liter. Defects in cholesterol metabolism, together with intrahepatic cholestasis, may lead to production of poor quality bile and malabsorption of fat and fat soluble vitamins. Reduced synthesis of proteins such as albumin, clotting factors, thyroid binding globulin, and pseudocholinesterase. Impaired hormone biotransformation, reduced production of modulator proteins, and reduced protein binding leads to increased circulating levels of hormones such as insulin, thyroxine, T3, aldosterone, and estrogen. So the indirect effects on CVS first would be hyperdynamic circulatory state are almost invariable in end-stage liver disease due to one is peripheral vasodilation by the endogenous vasodilators that bypass the hepatic metabolism, that is nitric oxide and glucagon. Second reason is portal and systemic shunts. Whereas the third reason is low systemic vascular resistance results in high cardiac output and high mixed venous oxygen saturation. Other cardiovascular changes are intrapulmonary and arterial venous shunting, pulmonary hypertension may develop, tachycardia, bounding pulse, and ejection systolic murmur is seen. On the pulmonary system, there is a syndrome called hepatopulmonary syndrome. This is the presence of abnormal intrapulmonary vascular dilatation that can cause profound hypoxemia and can be very difficult to treat. It may be explained by decreased hepatic clearance of endogenous vasodilators, example nitric oxide. HPS is marked by the symptom of platypnea. There is shortness of breath occurring more in the upright position and orthodeoxia, that is O2 desaturation, occurring more in the upright position. It can be diagnosed by echocardiography. Patients are diagnosed when their VO2 is less than 70 mmHg. Some cases may be corrected by liver transplantation, and patients may receive a speedy course to liver transplantation if their VO2 is less than 60. Pleural effusions together with ascites can cause a considerable mechanical embarrassment of the respiration and a reduction in the functional residual lung capacity. Another syndrome that is seen is portopulmonary hypertension. The portopulmonary hypertension is defined as the presence of a mean pulmonary artery pressure greater than 25 mmHg. Normal is less than 20 mmHg in the presence of normal pulmonary capillary wedge pressure. It results from excessive pulmonary vasoconstriction and vascular remodeling that eventually leads to right heart failure. It is also diagnosed by Doppler echocardiography. Metabolic changes, fasting hypoglycemia. Due to reduced glycogen stores and electrolytes, what are the metabolic changes you see is sodium and water retention. It occurs secondary to relative hypovolemia and secondary hyperaldosteronism. Then there is dilutional hyponatremia, there is hypokalemia, there is hyperkalemia also, hypomagnesemia is also seen. If you see the changes in the acid-base disorders, it can lead to respiratory alkalosis. This is due to hyperventilation, which is secondary to ascites and hepatopulmonary syndrome, which is most common. Whereas metabolic alkalosis can also be seen due to the potassium-using diuretics, hyperaldosteronism, or vomiting. Metabolic acidosis can also be seen in renal failure. CNS changes, it causes hepatic encephalopathy. Hepatic encephalopathy is a syndrome marked by personality changes, intellectual impairment, and a depressed level of consciousness, which occurs as a result of diversion of the portal blood into the systemic circulation, that is portosystemic shunting. Acute encephalopathy occurs in fulminating hepatic failure. There is cerebral edema and also increased in intracranial pressure. Hepatorenal syndrome. Definition. Hepatorenal syndrome is a functional and reversible form of renal failure that occurs in patients with advanced chronic liver disease in absence of other identifiable causes of renal pathology. The distinctive hallmark feature of hepatorenal syndrome is intense renal vasoconstriction caused by interactions between systemic and portal hemodynamics. So there is decreased effective arterial volume, and this causes activation of vasoconstrictor systems. The NSAIDs inhibit the prostaglandin synthesis and hence potentiate renal vasoconstriction with the resulting drop in the glomerular filtration. Thus, the use of NSAIDs is contraindicated in patients with decompensated cirrhosis. So the diagnostic criteria, that is all must be present. Advanced hepatic failure and portal hypertension, low GFR, which is the serum creatinine more than 1.5 milligram per deciliter, absence of shock, significant volume losses, ongoing infection or nephrotoxic agents, absence of sustained improvement in renal functions after intravenous saline infusion, proteinuria less than 500 milligram per day with no USG evidence of obstruction or parenchymal renal disease. Hematological problem, anemia may be the result of nutritional deficiency or toxic bone marrow depression or gastrointestinal bleeding from the varices or erosions. Now, coagulation defects arise from thrombocytopenia, platelet dysfunction, and decreased levels of circulating clotting factors. Drug disposition. Cholestasis will reduce absorption of fat-soluble drugs after oral administration. So patients with liver dysfunction may be particularly sensitive to opioids and benzodiazepines due to the altered end organ sensitivity. Portal hypertension, it can either be prehepatic, hepatic, and posthepatic. Prehepatic is mainly due to the thrombosis, either portal vein or splenic vein. Whereas hepatic, can be pre-sinusoidal, sinusoidal, or post-sinusoidal. Post-hepatic portal hypertension can cause Buchiari syndrome, inferior vena cava webs, or cardiac causes can be there, like restrictive cardiomyopathy and constrictive pericarditis. So, what is portal hypertension? Elevation of hepatic venous pressure gradient to more than 5 mmHg. It is caused by combination of two simultaneously occurring hemodynamic processes. Increased intrahepatic resistance to passage of blood flow through liver. Portal hypertension directly is responsible for two complications, that is, variceal hemorrhage and ascites. In the GIT, it causes the portal hypertension causes variceal bleeding, ascites, and spontaneous bacterial peritonitis. So the take-home message would be avoidance of hepatotoxic medications like NSAIDs, valproic acid, erythromycin, ketoconazole, and chlorpromazine. So talking about the anesthetic agents and liver functions, the anesthetic techniques would be avoid hypotensive techniques, avoid hypotension and hypoxemia. Ascites should be, there should be a large amount of fluid that should be drained. Concentrated albumin solutions to correct the hypoproteinemia should be given. Fresh blood should be given to prevent hypocalcemia. FFP of about 12 to 15 ml per kg to correct the dilutional coagulopathy and maintenance of temperature. In regional anesthesia, it is contraindicated if the PT is more than 2.5 seconds or if the platelet count is less than 50,000. Spinal and epidural anesthesia carry the risk of epidural hematoma and paralysis if there is abnormal clotting. The half-life of lignocaine is prolonged in liver failure, but this is not significant. Halothane hepatitis, the incidence is about 1 in 7,000 to 30,000. Halothane anesthetics, it is higher in women and middle-aged and obese. So unexplained liver damage within 20 days of halothane exposure in previously normal patient, it will be defined as halothane hepatitis. The clinical features would be malaise, anorexia, fever within 7 days, jaundice within days to 4 weeks. Diagnosis is based on serum antibodies and a gross rise of transaminases. Risk factors are high seen in recent previous exposure or previous adverse reaction in obese patients, in females, or patients with drug allergy. So halothane should be avoided if it is given within at least 3 months of the previous exposure. Previous adverse reactions have been reported like jaundice or pyrexia. Family history of hepatic reaction is there or a pre-existing liver disease. Effects of hepatic dysfunction on anesthetic agents. If you see benzodiazepine, since diazepam and midazolam is metabolized by phase 1 reaction, the hence recovery and elimination time increases in the patients of cirrhosis. IV induction agents, thiopental has no change, whereas propofol and intomidate, there will be prolonged elimination. Muscle relaxation, succinylcholine is prolonged. Mivacurium, pancurium, and VEC are prolonged, whereas ATRA is unchanged. So it is the safest to use. Thank you. That's all for today.